right, so here we are, bright and early. Congratulations everyone who's managed to haul themselves here for the 8:30 session. Just on behalf of my co-chair, Anaka Tahan from the Netherlands, I'm Jared Martin, obviously not from the Netherlands, all the way from Australia. And it's great to have the opportunity for the first session to delve into radioprotection. So we've got a local, Hilde Bosmans from Leuven, who's a medical radiation physicist, who's really just going to try to walk us through some radiation protection measures that are relevant and for clinically practicing, mainly for the surgeons. But the floor is yours, Hilde.
Okay, good morning, everybody. I'm happy you are here with me this morning. I would like to thank first Professor De Greef for inviting me here this morning in Brussels. It's an honor, and I'll try to make good use of your time. I know that radiation protection is maybe not a preferred choice. Some of you may be here because you have to assist in sessions like this. In our case in Belgium, it's like 2 hours per year as an obligation for surgeons, and I will try to make the best use indeed of your time. Let's see. Before I start, I'll tell you I have a couple of conflicts of interest related to this session. I have research projects with Agfa, Siemens, and Cefla, Newton, producing the Newton. I will show a few images of these devices. And I'm also a shareholder of Kylum, that's a spin-off company, and they do dose monitoring. But I'm not trying to sell these products at all. I just use them to illustrate a few of the principles I'm going to try to illustrate. Okay, when Professor De Greef asked me to speak here, I asked her a few questions because really it's my aim to bring something useful for you. And I asked, do you use X-rays during surgery for this Dupuytren disease? And she basically said, no. Okay. Then maybe you use X-ray images or CT images for diagnostic purposes. And the next answer was no. Okay, then you ask me to speak about radiation protection. This is going to be very simple. If you don't use them, there's nothing to say. Maybe that question I did not ask her, but I presume that maybe not all of you do full-time surgery for Dupuytren disease, but maybe you have also other surgical procedures where maybe you use X-rays. So this brought me to the following overview of my lecture. I presume some of you do use X-rays for surgery. So that will be part 2 of this lecture, just a type of general overview of radiation protection for surgeons. But I'll start off with a more specific introduction. So I'll speak about justification, how to justify the use of X-rays if you basically don't need them or if there are alternatives. And then Professor De Greef told me something else, you know, people consider radiotherapy procedures for this disease. I said, okay, I can make the link between just X-rays and this radiotherapy. So that comes in section 2. I will speak a little about optimized imaging for X-ray for the hand and innovative techniques, which are probably an opening and may be interesting for you, maybe on the semi-long run, where maybe X-rays could come into place if you want it, if you think these images are useful. So that's the overview, and I got like 1 hour to go through it. So I prepared, if you want, 65 slides. So there we go. You may not use X-rays for the surgery procedure. Some of you probably do. And if you do, or if you don't, well, anyway, it starts with justification. That is one of the 3 main pillars of any legislation or any course in radiation protection. What are the 3 pillars? Justification, optimization, and dose limits. And I'm going to copy a couple of texts from one directive, the one that was published in 2013. It is a European directive coming from the Euratom, and so it may apply to most of you, I presume. Well, not the Australian participants here, but maybe most of you are from Europe. And in fact, this directive is in the Euratom legislation, and it is not a law, but it is a European directive that member states of Europe have to implement at some point. And they have to implement at least what is written there. They can go further, more detailed, but that legislation should be included as a minimum. So also in Belgium, it happened that this legislation we have to follow, and so therefore this text, I am going to show just a few lines of this text, may apply to, in fact, all of you here. So radiation protection starts with these three principles: justification, optimization, dose limits. So let's first think on justification. This is just literally copied from the legislation. First, this legislation starts telling, look, in the medical area today, there are important technological scientific developments, and we see that the use of radiation goes up. More and more people have access to this. The X-ray devices can do more. So you are going to do more with it. You are going to go for finer detail, maybe use smaller catheters, and so on. So that's an observation. And as a result of this, we have to justify. And this directive emphasizes the need for justification. And this directive has also just, I am just reading. Yeah, I'm not so sure whether here. This directive should therefore emphasize the need for justification of medical exposures, and they say also for asymptotic individuals, and with this they mean screening. I don't think that that's applied here. And then they say, you know, in the frame of justification, a big part is also what you tell your patient, then what you do regarding the recording or the reporting of the doses. And then in the same directive, also in the frame of justification, those reference levels come into play, and those indicating devices. But what is it? Well, here it is. That is what we copied. Decisions introducing a practice shall be justified in the sense that such decisions shall be taken with the intent to ensure that the individual or the society benefits from the results. So the disadvantages have to outweigh, or the advantages have to outweigh the health detriment that it may cause. Decisions introducing or changing an exposure pathway, or so a change should also be justified before you actually do the change. It goes further. Here we are into the law, and the law says whenever you start with something new, so whenever you start using X-rays, you have to justify it before you use them. If sometime later there is a review of existing technology, you have to justify it. So you cannot just justify the use of X-rays in the 50s and then continue during 100 years. Now, when there is something new, you have to justify this. And you have to justify it for the patient, for occupational doses. That means you, when you work, and you will get irradiation as well. So the justification, not just what does it mean for the patient, but what does it mean for you. You cannot just start with the technique where all of a sudden you get an enormous amount of radiation. That's not acceptable, that's not justified. So you are also protected by the law, and also for the public. So if you would start with some practice where you are going to irradiate all the people in all the corridors of the hospital, it's not going to be easy to justify this. Okay. Practice towards this hand surgery session. Justification make also not using X-rays because there is an alternative, for instance, using the microscope and just well, just if you don't need it, just not use it. If you would be using X-rays, then you can do this, even if Professor de Greef can do it without it, but then you need a good reason. And if you have a good reason, you can get it justified. What can be a good reason? Well, I'll give you a very strong one. If you have a medical reason, and I tell that to all my medical doctors, and I'm mainly teaching medical doctors, don't be afraid of these radiation protection authorities that come and inspect you. If you use a dose for a particular reason because you're going to help your patient, you tell, I help my patient, done. Right? You have a strong voice there, and that an inspector cannot normally check this. Okay, so if you think for your procedure you need it, it is justified, but maybe you have to write it somewhere in the procedure map that goes with it. Or there is this extra possibility to justify that we call ALARA. That's if you go home when you want to use like one new word and go for ALARA. This is applying the ALARA principle means using an X-ray dose as low as reasonably achievable. So it's not as low as possible. It is as low as reasonable. So that means you can think. I'm now not thinking of the practice in the surgery room, but maybe for the diagnosis, as low as possible would mean never ever X-rays. But if the alternative, for instance, an MRI is absolutely not available, and with X-rays you can come close, it's reasonable to use X-rays. So also even economic reasons can come in and allow you to use a certain technology. Okay, here it's easy. Probably for Dupuytren disease, you don't need it. If you use it, justify it. Tell why. And it can be a medical reason, or it can be that something is not available, right? So there were 3 pillars. I'm just going quickly over this. I don't like this, this type of introduction really, and a lot of text. I'll show you images in a moment. Justification is 1, optimization was a 2nd, and dose limitations is the 3rd. So optimization means once you're justified, it is common practice to do it, so justified. Optimization means you should use a proper dose. You should not exaggerate. What you do should be optimal. The dose should not be too high, and what you get out should be what you need. Those limitations mean that you cannot just exaggerate. If you take the ensemble, there are dose limits. You as a personnel, and if you should be a dose meter. There are limits for you, accumulated over like a year in Belgium, averaged over 5 years, but per year, for instance, we should not go above 20 millisievert per year for us, occupational people. That should be respected at all times. And in order to do so, we have to measure it, and there is a need for some follow-up. But justification starts, and probably for you here, Dupuytren disease, very easy, no X-rays, that means it's justified. Okay, let's go to the second topic, this X-ray imaging. You say, no, not needed, because it's soft tissue. I got the explanation and I agree. I do not disagree. It was not needed, but radiotherapy is considered. Okay, let me first tell you a bit on X-ray imaging. What is it, in fact? And I just took from the internet a picture of a hand. I've drawn these X-rays. What is happening in an X-ray image acquisition? These X-rays are going to interact with the hand, and then the result of this interaction is shown in the film or in the image. So that's basic. I've been looking for examples of X-rays of the hand, and I found one that I wanted to include in this lecture, and it's here. This is the first X-ray taken ever of a hand. What happened here? Well, you see on the left side a picture of Willem Röntgen, who found he discovered the X-ray. He did not invent them, he discovered them. And he was playing at that moment in the 1890s with cathode tubes, which you see shown on this little table here. And you see this thing was mounted on his table, and in his table he had a tray, and in the tray he had other things that physicists were using, mainly films. Now we speak end of 19th century, they started to work with photography for several applications, so he had films here, and on top of his films a few things like probably scissor, I don't know, some things. And at one point he had maybe played with this like in the beginning of the week, and then later in the week he wanted to do an experiment with a film, and he found that this film had something, showed something. And then he discovered that on the film there was a picture of everything that was on top of the film, and that must have been irradiated by the device on the table, because he recognized probably type of scissor. How is it possible? So that was the start. And then he discovered it like December 1896. His wife, preparing Christmas, was unhappy with her husband being there in his lab the whole time. But then she was invited to witness his first experiment. And this was put on his Christmas card of 1896, sent to all his friends. And within a month, in January 1897, there's a first publication about this. It went incredibly quickly. And yeah, okay, that's type of quality. So, what do we see in this image? Well, we see in this image that the X-rays that were generated here, and where the hand must have been and on the table, these X-rays have interacted, and the result is here. So, where you see something black, X-rays had been absorbed, they were gone, and where you see something white, X-rays were not absorbed, they were not interacting. So, this white and gray in the image is basically showing you where X-rays have been absorbed, yes or no, where there have been interactions. Okay. I personally, rather than using rays, I like to speak in terms of particles. I find that more easy, and for this, we just needed another person you recognize, Einstein. Einstein said, doesn't matter, particles or waves. Waves are basically particles, packages of little packages of energy. So this story of waves interacting with the hand, I'm going to replace it by particles interacting with the hands. What are particles doing in the hands? Well, they can basically do two things. They can be completely absorbed, we call it photoelectric effect, or they can be in part absorbed. And then there is a part is left, is not absorbed, and there is an absorbed part. And rather than showing you these atoms with electrons, I give you, I give you a name. Mr. Compton has explained this to us, and you see here this picture. So when the absorption is in part, we call it Compton. If it's completely, we call it photoelectric. These there are a few other, but that are the main interaction points. I need this later on in this lecture. So complete absorption or partial absorption, Compton effect. Okay, so X-rays are going to interact in the hand completely. Some particles will completely disappear from the beam, some will in part disappear, and some go through the hand. And if everything would be absorbed in the hand, it would not be a picture. Some go through the hand to make the ultimate picture. The energy packages that are being absorbed from the beam are typically in the order of 10 to 150 kilo electron volt. That depends on the kV that we set. If we put 150 kV, which is about the maximum we can do in CT scanning, then the maximum energy is 100 kilo electron volt. If we go to radiotherapy, it's very similar. There is a beam. You see that I've drawn it a little bit different. It's the different frequency radiation. A particle in a radiotherapy beam is not like 100 kilo electron volt, but goes up to 25 mega electron volt. So it is like 1,000 times stronger. And this is important on this scale. There are other rays or particles, whatever we want. And you see, for instance, here that we have X-rays. They have a certain wavelength, a certain energy here. Like, say, here they say from 2.5 kilovolt electron volt onwards, okay. The gamma rays used in radiotherapy, they are 1,000 times stronger. We can go the other way. Ultraviolet light is like 5 electron volts. So one X-ray particle is 500 times stronger than an ultraviolet particle, and even much more stronger than light. So you see immediately that with these absorbed particles, there is a potential to do more, that they are probably a little bit more harmful if one particle is equivalent to 500 ultraviolet particles. And you know, for ultraviolet radiation, you have also to protect yourself. So with X-rays, it's even a bit more dangerous. We go up in scale from, from not dangerous at all up to like more dangerous. There is another concept I need, and that is the dose. And the dose is basically the amount of particles. So not what happens with a particle, but how many particles are we sending in. And this is expressed as follows. If you take the total energy that these particles will give in your tissue and you divide this by the mass of your tissue, then you have the dose. And there is a unit for this, an energy of 1 joule given to 1 kilogram of mass, that is called Gray. And I have looked on the internet to find a picture of Mr. Gray, and yeah, you don't come up with it, you don't find the scientist, you get 50 Shades. It was, I've not included it here. The radiotherapy unit is the 1 Gray. So this is a high dose. In radiology, we are like 1,000 times smaller. We have milligrays. Okay, now I come to the point I want to make. This slide I copied from my colleague in radiobiology. We are here in the DNA, and now I start knowing nothing anymore apart from a little bit of physics. And so if you give 1 Gray to a tissue, so in a local 1 Gray, then you create with this 1 Gray 40 double-strand breaks per Gray. So 40 double-strand breaks, you know, DNA cut in 2, like you see it here, cut in at 2 positions, 40 per Gray or 0.04 per milligray. And I work in radiology, so I'm concerned with the second here. For the single-strand breaks, you find 1,000 of these breaks per Gray. And typically, like a radiotherapy session, I think it's like fractionated and so on. If I've understood right, it's like 2 Gray per session. So we are here, the magnitude of radiotherapy. In radiology, there are not that many, but there are some. Okay, good. What do we need more? Well, X-rays are given to an organ, and we may be interested, for instance, in your application, irradiating the hand. The hand has several parts, you know better than me. But for radiation protection, there are only 2 of interest in my case. Well, in my case, I mean, in following the ICRP recommendations, the skin and the red bone marrow. For the personnel, if you work with X-rays, there's probably the dose to your eyes, the dose to your skin, and then whole body. Okay, what is of interest, what is useful? That is the concept of effective dose. Now, if you ask me, well, that's how I tell my students, what is the effective dose? Well, it's probably the dose you effectively want to know. The rest you don't care. If the effective dose is low, the risk is low. If that's high, the risk is high, and you are sure. And whether you speak on X-ray of the hand or X-ray of the feet or the abdomen, if you bring it to effective dose, you use the same language and you can compare. So effectively, there is a direct link there with risk. So that's why we put time in using this thing. Now, how is it calculated? It starts from what is the dose given to the different organs. And the dose is the amount of absorbed radiation, like I've said, how many particles are interacting. And then, you know, that there is a difference between irradiating one organ versus another organ. Some organs react more in a more, how to say, suffer more from X-rays than others. And the ones that react most in a, well, where you can induce cancer with lower doses are here on the top row, the bone marrow, the colon, the lung, the stomach, the breast. A little less aggressive for the organs, for the gonads. And you see here the skin, that's also an important one. The skin, in fact, is very low. You see here the weighting factors. Giving a dose of 1 gray to the skin is 10 times less harmful than giving it to the breast or to the stomach. That is what this table says. So how does it work? You calculate, or you not. If there is a reason, or if you need the dose to report to whatever, you ask your physicist, because in Belgium, for instance, officially we have to calculate the dose. We are certified to do so. So you start from the dose to any of these organs, you multiply it with its weighting factor, and then you sum over the dose times the tissue weighting factor, and you get something that we then express in millisievert, and then it goes as follows. If you have, you or your patient, a dose of 1 sievert, then you have a 5% excess risk of death from cancer. But 1 millisievert, that's for radiotherapy. We work with millisievert, 1,000 times smaller. 5 per 100,000 persons per millisievert effective dose may develop, well, 5% will have an excess cancer. So 5 per 100,000 per millisievert. You're probably never going to find which one this is. 5 per 100,000 patients irradiated. Okay, how high are the effective doses? I have here brand new research from my team. This is about dual energy CBCT. Normal, just CBCT without dual energy is half of that. But the important thing here for you working at the hand is that the hand has the lowest dose. And I'll show you here where they are. So what we see here is age groups. So, okay, I presume you mainly work with the more aged population. So let's go here. You have adult female, adult male here, and the colors are the different organs. And we go from ankle, hand, knee. So the blue is the hand, look, the lowest all over. For CBCT, lower than the effective dose for the knee, for the ankle, it's probably what you expected, right? Well, that's what I expected. And the main reason is that the hand is thinner than, for instance, a knee. So you need less radiation to get through the hand and make an image. That is the main reason. We can do the follow-up in a dose monitoring program, and that is where I have this little conflict of interest, because we co-developed this. What you see here is the list of all our departments in UC Leuven, and I picked room number 2 in Center Radiology. And in that room, we do a lot of procedures, including procedures of the hand. So I have found them for you here. This is the mean dose area product. I'll come back to, no, I don't come back to this. This expresses the dose. And you see it's all like this. And oops, this is a hand much lower than the other and here the wrist, also a much lower amount of dose given for these procedures. We can also express it in terms of effective dose, and then, yeah, obviously it's in Dutch because we use it in our own language. Here in the same list, or similar list, X-ray of the hand, we have effective doses of 5.5, 10⁻⁴ millisieverts. So in the order of microsieverts, this is really low. And now I'm going to calculate it even through. I hope I didn't make mistakes because this doesn't come from other textbook, it's just me thinking. Imagine you give a dose of a dose of 1 milligray to the hand, to just one hand. Then, if you irradiate a hand, you will irradiate the skin and the bone marrow, of course, but not all the skin of the patient, right? Just the hand. So the whole dose to the skin has to be divided by, or multiplied with the fraction that the hand is from the whole skin in the patient, the same with the red bone marrow. But I just focused here on the skin. So we give 1 millisievert to 1% of the skin. We have the weighting factor for the skin here, 0.01. So, and then that is the excess risk. So if I multiply all this, I think the total excess cancer risk of this X-ray to the hand is 5 per billion. So 5 per 1,000 million. It's impossible to find these. This risk is really, really low. And that's good, huh? There's nothing against it being very low. Reduction in the induced cancer risk for the personnel. If you do hand surgery with X-rays, maybe not for Dupuytren, but for other, you may use a C-arm, and then you irradiate the hand. The hand is very thin. You need only a bit of radiation to make these images, and if you only give a bit of radiation to make the image, there's only a bit of radiation coming out in terms of scatter radiation. And there is also no magic. It goes linear. Still, you will have to keep distance from the source. Okay, this brings me to the next topic, optimized imaging with X-rays. Right, I'm not sure I'm going to motivate you to use more X-rays, but I'm going to tell a little on how it could go. The first thing is, maybe for the hand, that's what we think, you probably need very good resolution. What is done there, or how is this expressed? Well, we would typically do a test in which we irradiate what we call an edge. So that's just a foil of metal, and we want to see a very sharp edge. So here, that is what we measure, an edge, and then we do some, no magic, not Fourier transform, and then we find here in this curve what is happening to all the frequencies in the image. We may think ideally that we want to see all the frequencies in the image, all the frequencies in the hand also into the image, so that we see everything. Maybe it's not exactly what we need, but anyway, we want to see as many. Now, you can see frequencies. You can tell me some frequencies in the image. My goodness, what is this? Well, the high frequencies in the image are the fine details, and the low frequencies are the not so small details. In fact, you can maybe, if there are musicians or people playing music, you may know, if you, for instance, play the piano, you create frequencies and that you can hear. And the best system is the system where you can hear all the frequencies, or you have the best ears if you hear all frequencies. Although I'm not 100% sure you want to hear all frequencies, because then you hear the music and the noise very strong. So, but hearing the music starts with hearing the subtle, all frequencies, the low frequencies and the high frequencies all together. And in an image we have them also, so the high details and the small details. And the result is, as I say, a modulation transfer function telling what is happening to the frequency. So in general, we would want this to be as high as possible, that the frequencies in the hand are also visible in the image, and that can be detected by the human system. So the higher, the better. But maybe not one all over, because then all noise would also be very strong. But anyway, higher. There is, okay, next to this, we want the detector to absorb everything, not to lose data, absorb everything. And we combine this in what we call the DQE. The DQE, if you want to remember one other magic thing, DQE. Higher DQE means better detector. And the DQE curve is something like this. The higher, really the higher, the better. So what did we do? Together with AGFA, we have tested 7 brand new detectors. And in fact, we wanted to answer the business question for AGFA. Do we have to go to detectors with small details, small pixels, high modulation transfer function, high DQE? So we end up with curves like this. This is for one radiation quality. So the higher, the better. And we do see differences. For instance, this blue detector here, that's a really nice one. And it wins also for the higher kilovoltages. Normally, this is what you would use for X-rays of the hand, low kV. That is what you use for the others. And then we see, for instance, the green one, really not so good. Okay. Proof of the pudding, we did this on a hand. This is a frozen hand from the pathology department, so it's not in vivo. So we put this hand, since we used we put the hand and then the detectors under it, so it's the same hand irradiated at the same moment. And maybe you can detect which image you prefer most. I'll tell you which one we thought were the best. That was the blue one in the curves, and that was the gray one. We thought these were better. I'm not sure. We could organize a polling here, but I forgot how to include a polling in. Here is maybe even more enlarged. Our summary of this study was, as a physicist and also with radiologists who have looked with us, we don't see the difference. And I'm not sure it is very clinically relevant to invest a lot of money in this versus this. So we can see it, but not sure. But in fact, this input has to come from you. That is where ultimately we have to work together. And I have a lot of projects with not really with surgeons, but with radiologists helping us, because at some point, you see more than we do. Okay, last point, innovation. I would like to show you what I thought is maybe going to be innovative for you. Let's first say something quickly on 3D imaging during surgery or to prepare the surgery. You may have access to these 3D imaging devices that are mounted on the C-arm and that you can operate, in fact, during surgery. They produce high-resolution images, super high resolution, in fact, I think, but the rotation is not like in a second. It takes time, so there is a risk for motion artifacts. They are mainly applied for bone, as far as we know. For soft tissue, it's difficult. If you really need soft tissue, like for instance in our hospital, for neuro applications and imaging during surgery, they have a CT scanner in the operation room. The CT scanner that we have in radiology has the resolution of the CT, which is a little bit less than what you could get with the C-arm, but it is very fast and has better soft tissue contrast. we work, I'm sorry, yeah. I thought you saw this or the slide already. I was looking wrongly here. The new thing in our hospital is a photon counting CT. I did not check for an image of a hand, but this is one I got from Dr. Noppe, who's a musculoskeletal radiologist. And you see in this, that level of the pelvis, the fracture she saw immediately, this one here, blue arrow, and the subtle fracture she saw with carefully looking to these images. The patient had arrived in the emergency department, was scanned with a normal CT scan, so this was detected, and then a couple of days later, check on the new scanner, and they saw more this is clinically relevant, and we try to go with other projects in this direction. So one of the questions I would have here, would you use an X-ray device if it gave you some soft tissue imaging? And then the advantage of using X-rays is that you do not have to have contact with the skin, so it's not like ultrasound, we have to put a sensor, but you can have like a source and a detector, so maybe it would make sense. Well, some innovation goes in this direction. What you see here is for 3 typical, not tissues, materials that we try to image, like oxygen, which is like soft tissue for me, for X-ray attenuation is like soft tissue, calcium and iodine. And you see here attenuation coefficients as a function of X-ray energy. Attenuation is high here and it's lower here. These curves can be characterized by 2 points. So if you would have like this point and the gradient, for instance, you would know, okay, this is the curve of iodine, and this is the curve of calcium, and this is the curve of oxygen, for instance. And with 2 measurements, it's possible to pick these different tissues. So if we could measure with X-rays, like a point here of that curve and a point there, then with these 2 combinations, we would know at this place there is, what is it, iodine? And if at another place in the image, we would measure this point and this point, we would know there is calcium. And for soft tissues, and it's similar, and soft tissues and fat are also different, so that makes it possibly interesting. So what would we need? 2 measurements to find that curve, and once we have the curve, we know which material or tissue is there. Why do we need 2 measurements? Because there are 2 effects. That is why I introduced photoelectric effect and Compton effect for you. There are 2 interactions, and every material has a bit of photoelectric and a bit of Compton in different proportions. And if we do 2 measurements, we can split this. So that's just the physics behind this. We don't have to remember this. I just thought I'll close the circle. So if we have 2 measurements, we can resolve it. Like, well, okay, let's do it. We can make, well, not we, the companies, the devices can make, for instance, an acquisition with higher energy, high kV, and an acquisition with low kV. And then you give these 2 acquisitions to the computer, and you ask afterwards to the computer, where is the iodine, where is the calcium, where is the soft tissue, where is the fat? And that's the type of game we play. We can do it for X-rays, we can do it for CT. So here is an example on X-rays. Actually, I should have included car imaging also as a conflict of interest. We do some work for them as well. So if we use, with this detector, here, the plain image is like this, the digital radiology image. If we ask, show us the soft tissue, that is what we get. Show us the bone, that is what we get. And these 2 informations are split, and maybe it's easier to evaluate the soft tissue. And this, look, I was lucky. The dual energy CBCT in their leaflet also won with the hand. And I asked just cases. We had a meeting with these people Thursday. So just in time for this presentation. What you see here is, I'm going to read it, that's more safe. A cystic tumor with a benign MRI appearance, okay, like a bony cyst. I presume it is, I think it's this here. So that's the MRI image. That is a classical CBCT, just the extreme good resolution, showing the bones, not the soft tissue. And here you start to see some of the soft tissues, I think, at least muscle versus fat, I think. Here is an example that shows it even more clearly. Here we are obviously in the knee, and I think you can start seeing differences in soft tissue. That is what we aim for. And then I was lucky, like this should also rotate. I don't know why it is not. Let me check. Oh, yeah, there it goes. So this is from this 3D acquisition, soft tissue image versus the bone. It is a CT scan with super high resolution. So maybe it's interesting. I don't know. We don't have it yet in our hospital, but it is, you can buy it. And we hope to buy it as well, but this system might first go to the dental department. Okay, that's what I wanted to tell in terms of innovation. Maybe interesting, I hope. The last part, I'm going to go quickly and fill just the hour like I was asked to. Classical radiation protection for surgeons. I started off with 3 main principles. Here I'm going to give you 3 other main principles. How do you protect yourself when you use X-rays? Very easy, I think. Limit the time you use X-rays. Increase the distance between you and the source of X-rays, and then shield yourself with lead. So let's go over it. Well, first, I would like to just focus your attention to something. I presume you know, but if you don't, it's better you know. For the patient, the source of X-ray is the X-ray tube. For you, the source of X-rays is the patient. It's where the X-rays are going to interact with the patient, because there the scatter radiation is made from the Compton effect, and from that place the X-rays may hit your body. So if you have to stay away from the source, actually you have to stay away from the part of your patient that is irradiated. Unfortunately, that's probably exactly what you don't want. Well, don't want is not the right word, but you cannot. Okay, so if we say keep distance, it's not from the source, it's from the irradiated part of your patient. Okay, let's go into detail. Time. How can you limit the time? First, why would you do it? Well, there is obviously a link between what you do at the patient and the amount of radiation that comes into your direction. So that is why. How can you optimize it? Well, less radiation, less time. And there are different ways to interpret this, like limit the number of images, limit the number of X-ray pulses, limit the number of retakes. With the retake, we mean an image you have to repeat because the first one was not good. If you make series, make that series shorter. And then the frame rate, that's the number of images per second. Okay, if you go with 10 images per second, your dose will be lower than if you used 15 images per second. I think it's logical, right? Just less X-rays. But it's also in fact what you give per pulse. You can give huge pulses and you can give short pulses. So that comes into play. And one good trick may be to set up your system such that the low dose mode is the routine thing when you start up the system, and that your personnel knows how to go to the higher mode if you need this. And not the way around. Not thinking we start at a very good quality, and if the quality is too good, we're going to reduce the dose. No, the way around is better. And that worked in our CAT lab. Also, you need more powerful pulses if you go to thicker amounts of patients. Now, thicker amounts of patients for the hand is not, well, yeah, you can say, if you can choose this direction, the amount of patients is going to be thinner than if you go lateral, right? But in the abdomen, it is more clear, of course. If you have to go lateral versus AP or oblique, you reduce the dose if you take the shortest distance. Then, of course, knowing how to use your system, filtration, grid, magnification views, collimation, your people should know this, or if you press the buttons, you should know how that works. Yes. So there are tons of buttons. For instance, there are buttons to select a proper program. And if you don't have a program for hands, or maybe ask one, or at least ask which one you should choose. Then there are programs, so that's here, there are possibilities to set the dose level, and there are also possibilities to set the frame rate. Time is also how efficient you work with your system. So if your team knows very well how to use the device, the doses will be lower because they will be right immediately. So training is important. Also for fluoroscopy, I'm not sure it applies a lot to the hand, but surely for other like interventional radiology and cardiology procedures, the rule is normally you use it. So this fluoroscopy, so this this series of images, you should only use them if there is something that changes, some motion. And if everything is static, it makes no sense to keep on irradiating. Fluoroscopy is intended for moving things. There are options such as last image hold, which just means pick up the image from like 10 minutes ago and recheck this instead of making a new one. There are also dose-reducing options, and teamwork, team spirit is probably the most important. Work together to make it fast, structured, optimized. Then there is distance. As I told you, not from the focus, but from the patient. It starts with knowing when is radiation given. Normally there should be, at least in our hospital, as an obligation, a red light flashing if X-rays are being produced. So if that happens, you know you have not to run away, but to know what you're doing and where you should be. I always tell my students, if they first see an X-ray system, check first where is the tube, because the tube will give the radiation that goes to the patient, and then that is the source of radiation. And the X-ray beam will enter the patient, and where it enters, the interaction is more heavy than where the X-rays come out, because the X-rays are reduced already. So it is this entering place that is the biggest source for you. So you have to know where is the tube to know where is your source of radiation. And then there are, of course, several possibilities. And you see, these are the classical pictures. You see the tube, the beam is starting from here, irradiating the patient. And in red means highest dose, and orange less, and green obviously is more safe. And this is a good situation, better than the tube up. That's not shown in this picture. Here, you see the patient on the table. The X-ray tube is here, irradiating the patient. So most of the scatter radiation will come back from this point, not from this point. Here, the beam is already much reduced. So if you have the choice between this place and the other place, you go for the other place, because the X-rays are just more intense where they enter the patient. So if you put yourself here, you put yourself in the biggest intensity radiation. So you have to know a bit where to stay. Then there is distance. Other things, keep your hands out of the beam. Put the detector as close as possible to the patient. If you are not needed in the room, then please leave the room. Try not to be standing next to your patient. Use the power injectors of contrast agent if you apply these. And then during injection and imaging, just stay either with the power injector at a distance or just go 1 meter. Right? And all this is the result of the fact that the inverse square law applies, which is, if this is the source, with every doubling of the distance, the amount of radiation that hits your body divides by 4. So you go like in terms of multiples of 2 away, but irradiation leaves or reduces with multiples of 4. And that goes fast. So it is a good idea to keep distance. Now finally, last point, I'm nearly there, shielding. Whenever possible, put lead between the source and yourself. There are, you can go over your own body. It starts with a lead apron to protect all the sensitive organs that we've seen in the effective dose tables, so the stomach, the liver, the colon, the skin, the breast, the gonads. Okay, they are all protected in the lead apron. Then you want to protect your eyes. There's sometimes some discussion on how about a lead cap, the lead head, but we don't give advice in favor. We say it doesn't help because this cap is not going to protect you from X-rays that come from your patient unless your patient is hanging at the ceiling. But I don't think that is the case. So very important are the lead that you don't have to wear yourself, and that is hanging at the ceiling for you or hanging at the table, like these lead sheets. They are really very effective. They are thick, and you don't have to carry them, so they are really made to protect you. There are obviously, for the people being a lot of time in the room with a lot of procedures, not of the hand. I never ever think that even for complicated surgery, the dose will be very high because the hand is very thin. But for abdominal work or spine, when that takes long, there are inventions, of course, like you see here, where lead aprons hang rather than that you have to wear them to avoid back pain later on in your career. So I think I'm more or less there. I would like to thank you for having been here with me to start this way Saturday morning in Brussels. I thank, of course, our radiologists. I have already thanked Professor De Greef, but here I just thanked everybody who enabled me to make this presentation. And I would like to start. This is a picture from a couple of years ago. Some of you may recognize this building, our royal palace that was on a winter evening. I thought it's just nice to finish up like this. Thank you.
Thanks, Hilde, for a great overview of radiation protection, everything you wanted to know but were afraid to ask. We've got a couple of minutes for any clarifications or questions from the audience. Please.
Congratulations for your great talk. It's a very dry subject, and I was really listening in a passionate way. I have to congratulate you. One simple thing, you had a general talk about the use of X-rays in the OR. We use very small C-arms with a very low dose, yes, which only, gives a bit of scattering, maybe at 1 meter, but is of a very low dose. So I think the discussion might be slightly different because, as you say, our hands do not take a lot. If we put a lot of metal in it, it takes a lot, we have more scattering. Mm-hmm. But I think the discussion is extremely different because, as you say, when you use X-rays, make a red light, well, I don't think we need this in our setting.
Yeah, I agree completely. And I forgot to include something on the mini C-arm because, no, you're right, but everything is mini. The doses are really low, and we use low kV to go through low parts. For us as a physicist, this is a challenge because if we come with our protocol for the C-arms, nothing works for the mini C-arms, and we are still discussing. And I agree, the source of radiation is very low, yes.
And this is also a discussion with the personnel we have, and they say, oh, they are using X-rays, beware. I say, come on, it's only for me and for my assistant that it might be dangerous, but not for you guys. And this is always an ongoing discussion. It is very difficult to go through.
I agree, yes.
Thank you, Hilde. It was indeed very, very interesting and learningful. I have a question because at this point, there's more and more interest in 4D CT, so where we have the motion. Does that increase the amount of irradiation enormously?
Yes and no. If you do it the classical way, well, with every image. With every 3D stack, you just, yeah, it goes linear. If you do 10 rotations with a CT tube versus 1 to make an image, your dose is times 10. But we don't use this yet, as far as I know, in our hospital, but this will certainly be helped with new AI techniques. Because if you have like one complete 3D data stack and only subtle things are going to change through this acquisition in time, then I think we will need less data points to show the image completely. A lot of information from the first run will be reused also in the later run, so I expect a big dose reduction there. But as far as I know now, in our hospital, it's still linear. So if you decide to do 20 runs, it's going to be 20 times higher than if you only do 1. Of course, you don't do 20 times the best quality. And there you play on the fact that if you also for fluoroscopy, in fact, you do this. If we, as a human person, we look at a moving image, we see the image. And also, if I look in this room now, I see you now, but my eye is accumulating also a little bit information from just a few microseconds below. And also in fluoroscopy, that is what the vendors do. They show you this image plus a little bit of the previous images. Every image on itself should not be full quality because we integrate over time a little and then it becomes high quality for us. So these techniques make sure that, or have as an effect that you don't need a full quality at all time points. You can, yeah. And we look towards AI. In MRI, it's already common practice that the case base is not sampled completely and CT has to follow.
Okay, great. Well, look, we might save any other questions to the coffee break, but please join me again in thanking Hilde for giving up this Saturday morning to walk us through that.